it is my great pleasure to introduce Abhi Dalal. He is joining us today to lead us through a little mindfulness exercise just to kind of, we took in a lot of information yesterday and just to kind of clear our minds and be ready for today's lessons as well. So Abhi, with that, I'll turn it over to you.
All right. Thank you, Libby. Without further ado, let's go ahead and get started in the work. Um, and thank you, Libby, for having me. So let's go ahead and find a comfortable seat here and make yourself very comfortable. You're welcome to maybe roll your shoulders back if you wish. And you're welcome to close your eyes here if you're comfortable and begin to feel your seat on the chair. You're not thinking about your seat. You're simply feeling the sensations coming to you from your chair. Begin to notice now the sounds coming to you. You may notice an airplane in the distance or whatever sounds around you. Let your perception rest at that point and trust this process and allow yourself to rest with your awareness. Don't worry about doing it the right or wrong way. We're simply allowing ourselves to be present with what is. Continue to allow the sounds to come to you. And you may gently open your eyes. Just want to make one or two quick points about mindfulness. It's very hard to talk about it unless you first experience it. So thank you for trying the first part of this exercise. And I've seen the benefits of mindfulness with my senior citizens at Parkview Community Hospital and also myself. It cured my irritable bowel syndrome. And many of you have probably heard of this word before and know about the many clinical benefits. However, I think one of the largest benefits is relational. It helps us to be really present when working with others and teaming up with those we might have different values with, for example. It gives us an understanding about ourselves and the relationship with our circumstances so we can be more understanding of others and navigate those with different dynamics and values so we can best spearhead patient and family centered care. Ultimately, by bringing this inner peace, we can help to spread it through our work. So without further ado, let's go ahead and continue with the second part of this exercise and plant seeds for our presence and our collaboration today and learning as best as we can from others. Go ahead and here you're welcome to close your eyes once again. And like before, find a position for your body that feels good. And let's take maybe 3 cleansing breaths right now. So inhale through your nose and exhale out through your mouth. To stimulate the vagus nerve, inhale once again. Exhale out through your mouth. Once more, inhale and let it go. And allow your breath to simply come in and out. And your wall, and just follow your breath as it flows effortlessly. Now, this is not a concentration practice. You come into the present when you notice yourself moving away from your breath, and you gently bring it back then. Continue to follow your breath for a few more moments. And if this breath practice is not working, you're welcome to return to the sounds or the sensations of your body, or just allow the present to be. Continue feeling for a few more moments. You know, when we begin to come into the experience of being present, we see how much suffering there is and our common humanity. When we make a mistake, we need compassion to help us acknowledge it and make amends. Like when we're working with our colleagues and we come with different values, for example. So, mindfulness is a stepping stone to plant seeds for loving welcomeness, compassion, joy to be with others. And it has a network effect from our relations to others. So I invite you here as you sit here quietly. Remember who you once were as a child. Remember your hopes and expectations. Remember the goodness in your heart. Feel kindness for yourself as if you can now be a loving parent to the child, teenager, or young adult you once were. Forgive yourself for your mistakes or failures and acknowledge how hard you always try. In this moment, embrace the totality of who you are, all of who you are, known and unknown, without judgment. And you may say these phrases after me. May I be happy and safe from harm. May I be healthy in body and mind. May I be peaceful and free of suffering. And I strongly believe that in every interaction with others, we leave something of ourselves. I think with inner peace and compassion, we can bring about a network effect. So bring this loving welcomeness, this compassion to all beings. And you may say these phrases after me. May all beings be happy and safe from harm. May all beings be healthy in body and mind. May all beings be peaceful and free of suffering. Well, thank you everyone for trying that. You're welcome to open your eyes. I know when I first started mindful compassion, it was very awkward for me, but I've seen the changes it had in my life and also with the senior citizens I've been working with. Um, so without further ado, I want to turn it back to Miss Libby Hoy and appreciate everyone trying this exercise. If you have any questions, you're welcome to email me. I'll go ahead and put my contact information in the chat box. And I think with starting today with this exercise, let's go ahead and continue with a loving welcomeness and joy that we're come together for in our humanistic mission to further patient and family-centered care. So, thank you, everyone.
Thank you, Abhi. That was such a great foundation for our day today and a nice transition from yesterday. And really, what resonated with me is may all beings be peaceful and free of suffering. That's a little bit of what we talked about yesterday. And I think now is the moment for all of us to be very intentional in creating that space and keeping ourselves well and whole and those around us. And just in general, I think being a little gentler with one another and the differences and putting them out there. So thank you so much, Abhi. That was really, really powerful. I appreciate that. All right. So the moving into our next session will be a couple of minutes early, but that's just gives us more time with our amazing patient partnership panel. So the patient partnership panel, for those of you who are joining us for the first time this year, has always been the foundation of the PFCC conference. As most of you know, I come to this work as a patient family advisor and started that role in the mid-90s and just learned so much through years and years of partnership and evolution of patient and family-centered care. And so as a result, really wanted to focus on this partnership panel. And I have to say, in the first few years, we had patient family advisors just sharing their experience about how they partnered with their organization to improve and make sustainable change. And then we realized the field was evolving and we needed to as well, and to really highlight the partnership. So this year, again, as in the previous few years, we've brought in both patient family advisors and the staff and facilitators who are partnering with advisors to get that partnership perspective. And so I am very, very pleased today to be joined by Rosie Bartel, Gilbert Salinas, Eli Quisenberry, and Carlos Benavides. I know I don't say that with the right roll, Carlos, but you'll forgive me, I know. All right, so let's go ahead, and if you guys want to pull yourselves off mute, we'll start the conversation. So Rosie, could I ask you to introduce yourself to all of our colleagues here today?
Sure. My name is Rosie Bartel, and I'm a mother and grandmother and educator and a new widow, which is a hard thing to experience, but it's the first time I have to say that. But my background is education, and I came to being a patient advisor about 10 years ago when I developed a healthcare acquired infection after a knee replacement. And the MRSA led to 55 surgeries, over 200 hospitalizations, being in a sepsis patient more than 12 times, and leading to an amputation first of my leg and then my hip and most of my pelvic bone. And so by doing that happening to me, I said to myself, I don't want this happening to others, and how can I help? And as an educator, one of the ways I could help was to share my story. And so early on, I was asked by a hospital to share my story. And then I was asked by the Institute of Healthcare Improvement to create a video about my story and to come to their forum to talk about my story. And as I did that, I then began to partner with other people. And I have to tell you, one of the people that I met in that first conference at IHI forum was Libby Hoy. And I remember thinking, I want to be her someday. I want to be like her. I want to be her. And then I just learned about her PFCC partners and her PFA network and began to be working, connecting with her. And I have to say, yesterday she described herself as a connector. And for me, that's what she has been. She has been a connector across the country and across the world. She has helped me open up my door to experiences I probably would have never had. And someone this week said to me, Rosie, how did you get so involved in everything that you're involved in? And how did you know what to get involved in? And I said, it was Libby Hoy. And he said, who's Libby Hoy? And I said, if you don't know Libby Hoy, you haven't experienced life. And so, when I think about partners and connecting and being involved as a patient advisor, this is the place I come to when I want to look for a new experience. If I want to take on a new role, it's here's where I come and I say, help me look at what I want to do next in my life. And so I want to say thank you to Libby and for having this forum always open to all of us as patient advisors. And I think on the other side, as people who are looking for patient advisors for hospitals and healthcare and even community groups that are looking for patients and supporters of what they do, Libby has been a partner and is a connector. And so I think that we, as she celebrates 10 years this year, we need to know that she has connected thousands of people to thousands of other places.
Wow, Rosie, I'm humbled. You have shared your story in so many different areas and really created impact by doing so, not just through your story, but really connecting your experiences to so many different improvements in the safety and culture of healthcare. So really grateful for your presence here today. Carlos, do you want to take a few minutes to introduce yourself?
Sure. Good morning, everybody.
Good morning.
My name's Carlos.
Oh, you're a little bit quiet, Carlos. Can you get a little closer?
Okay. Yeah, that's my problem. I speak very low. I apologize.
That's
good morning,
okay.
everybody. My name's Carlos Benavides. I'm one of the co-chairs at Rancho Los Amigos Hospital, and it's an honor for me to be doing that. Going into Rancho after my injury, I wasn't sure where I was going to, and thanks to Gilbert and thanks to administration and thanks to the staff over there, they've pointed me into the direction where I'm at. They've helped me grow. They've given me confidence. Now I'm president of 2 foundations, and I'm also president of the Los Angeles County Commission on Disabilities. I'm a C2 to a T1 tetraplegic. So I'm here to let people know that, you know what, there is life after injury. And like I said, thanks for the blessings at Rancho Los Amigos. They've put me on public. There's nothing that I can't do that anybody else can't do. Thank you very much.
Thank you, Carlos. I'm so glad that you've joined us. You've got a wealth of experience in the role of patient family advisor to share with our participants today. Thank you.
You're welcome. Thank you for having me.
Gilbert,
Good morning.
as the bookend of Carlos's partnership at Rancho, you want to introduce yourself?
Sure. Good morning, everyone. It's a pleasure to be here. As well, my journey began, I want to say, when I was 17 years old, and and I became disabled for the rest of my life. Being confined to a wheelchair really turned me into my own advocate. I really had to teach the world about accessibility, about caring for someone with a disability, and really trying to push people and advocate in the areas of housing, transportation, laws for people with disabilities. So I spent many years as an advocate. I also spent many years as an advocate in communities of color, working alongside addressing social determinants of health, I made a transition towards hospital administration about 10 years ago. And it was then when I met Libby Hoy, and I met Maureen Bizignano with the Institute for Healthcare Improvement. And I became an IHI fellow. I've been involved with patient and family advisory councils for many years now. We established the first patient family advisory council in LA County Department of Health Services about 12 years ago. It's long-standing. It's been around. Now it's used as a model with other outpatient clinics. And thanks to Libby and some of her work, has really helped to expand that. So it's a pleasure and an honor to be here this morning with all of you. I'm looking forward to learning from each and every one of you.
Thank you so much, Gilbert. And Eli, I've been so excited to have Virginia Mason join us on this panel. I've been a longtime admirer of the extensive advisory program at Virginia Mason that's been in place for quite a while, but always seems to continue to evolve and deepen the partnerships. And I know when you and I met at National Quality Forum recently, I was equally inspired by your commitment to partnership and the continuous learning aspect of it. So you want to say hello?
Yeah, so hello to the group, and thanks to Libby for the invitation. So my name's Eli Quisenberry. I'm on the management side, a senior director at the Virginia Mason Health System. We're based in Seattle, Washington, but with hospitals and clinics kind of all over the Northwest region, but in Central Washington in Yakima. I'm probably mostly for this group a testament to what a kind of a strong culture of patient experience and innovation can do for an individual, in the sense that I personally, I come from, a world of privilege and comfort, and probably would not have naturally found necessarily even this group or this passion without kind of an organizational culture to help, really emphasize from day one that this is just the natural way we should do things, is understand the voices of those that we're serving. The work focus for myself is maybe what I'll focus on most, because that might be most interesting for kind of the rest of our discussion. But I lead what is called our Virginia Mason production system efforts, and that's maybe just a fancy way to summarize elements of Kaizen, continuous improvement, lean, innovation, rapid cycle design, like insert whatever word I've come to understand. But I have responsibilities for both kind of organizational improvement initiatives, strategies, and that naturally lends itself to some collaboration with our innovation teams and our patient experience teams and strategies and our patient relations group. We run maybe 100, 150 improvement events, improvement activities per year, and while that's certainly not all of what that work entails, I think that's kind of the most tangible thing to talk about. And then our patient relations and experience group helps facilitate. We've got about 150 patient family partners that provide a range of services for us, including participating in improvement events, feedback on patient education forums. We have monthly listening sessions with this group. They share stories with our board. So I think we really, find a range of ways to bake in the patient voice into everything we do. Today, all of our kind of large-scale workshops are required to include patient family advisors. And so I think that's just one example of ways that we've tried to both make it a want, but also an expectation in kind of everything we do. Mm-hmm. Some of the challenges that I think we're thinking about that may or may not lead to more discussion later, but especially during COVID times, I think the challenge of how do we continue to engage with, patients when they can't necessarily come in. Mm-hmm. And I think that what lends itself also to kind of like the diversity and equity of the voices that we have in the Seattle community. And then I think also these days we're thinking a lot about speed and urgency. And so I think a lot of our previous strategies to bring in patient voices was all about, it took a little longer conversation. And so we're really kind of struggling and challenged with how do we kind of build in speed without losing kind of the purpose and respect that is. And so that's maybe a long-winded introduction, but that might plant some seeds for later.
Absolutely. Thank you so much. It's there's so much there, the culture and sort of the expectation. I love that, the expectation setting. It's just part of the way we do business. I think that you call it baked in. Over here we call it the funfetti approach. You know, the funfetti cake has it all built in. It has all the chips inside. It's not just on top. So I really appreciate that. Rosie, let me go back to you for a second and ask so since COVID, and Eli brings up such a good, important challenge to our advisory efforts, right? That's the whole reason we wanted to host this conference now and make it open, free, accessible to everybody, because we really feel strongly about the need to sustain our momentum in patient and family-centered care. What have you seen and experienced since COVID in terms of your level of engagement?
I think that during this COVID time, sometimes some of the hospitals that we work closely with might have sent you away or said, this is a time when you won't be coming on campus, you won't be part of, our day-to-day thing, but, there might be other ways you can help us. And I think also for me, it was like, okay, what else can I do? How can I be proactive? How can I look at this and help across the whole world, not just in little old Wisconsin where I live, but across the whole world. And again, it came back to, some of the organizations or some of the work groups that I work with across different organizations that then looked at what can we do to help the situation without stepping on people's toes or all without getting in the way. Because I think that's important. We need to look at the fact that, yes, we want to be there and we want to be giving advice at this time, but sometimes we're just going to get in the way and we're going to not be, productive and we're not going to be helpful. But there are other ways. And as I thought about this question this week, I'm thinking, one of the ways is that, all of a sudden I'm getting surveys from all kinds of places and asking me to answer, survey questions. And I hate surveys. I absolutely hate doing them. But I started doing them because I decided that this was important, and they were sending me surveys because they needed input, and they needed input kind of back to Eli's thing. They needed input now. They didn't need input 6 months from now. They needed patient input now. And they couldn't ask me directly, but they could send me a survey. And so I started answering these surveys and making it a priority to do them right away. And I think that's another way that patient advisors can reconnect and be involved. And so even though the door might have been closed, you might not have patient advisory council meetings, you might not be meeting, reacting or involved in the same way, look at how you can help. And I look at one group that the National IT Group said, what can we do at this time? And Lindsay led, and I lead that group, but Lindsay, our group said, maybe we need to help patients look at how to look at telehealth. And we created a one sheet in 2 languages, in English and Spanish, on how to approach telehealth from the patients, how to help patients approach telehealth, not to help the hospital so much, but to help patients. And I sent that to probably 15 or 20 different hospitals in my area. And every one of them said they were going to use it and are using it. They send it out to their clinics, they send it out to their, to their hospitals, to, everyone that's using telehealth, that they put it in their hands. So I think there's ways that we can help people without getting in the way.
I really appreciate that, Rosie. I think as advisors, we really have to be creative in this moment about how we contribute, and it may not look the same and probably shouldn't look the same, right? In order to meet our diversity and equity goals. So thinking really differently about it. And taking that initiative to offer yourself as a resource, I think is really important. And I love your honesty about surveys, but I also love that you've really made that an intention. Thank you. So Carlos, can you talk a little bit about the unique needs of the Rancho population, patient population, and sort of how your PFAC is helping to bridge those needs during this time?
Sure, thank you. Okay, COVID-19 has impacted our patients with disabilities in the following ways. Transportation issues. Um, we worry about ridership programs or leaving houses. Okay, they're vulnerable. They are vulnerable. Okay, due to the fact and the level of their injuries and their disabilities. A lot of them are scared to physically go anywhere, to leave their houses, in fear of danger of contracting the virus. Many of them are isolated, depressed, and not socially connected. At Rancho, we have the virtual support groups, many of them. We hold our patient advisory council meetings virtually. Um, this has helped people making sure that our patients are connected to us. We've been able to provide them with care through telehealth and face-to-face, and when necessary, visits, okay, if they come in. Through telehealth, they can speak to a physician, explain everything that's going on. The physician can tell them, you know what, come in, or you know what, we can discuss this over the network, and we'll continue from there. We design our programs in the Wellness Center so that patients can continue to do Zumba, online classes, along with various other programs that we offer there. Arts, just support groups, even different exercise. People with disabilities face unique challenges in housing, education, in the community integration, and the professional field. This pandemic has taught us something. It's taught us to include them in all aspects of life.
Fantastic. Thank you so much. Gilbert, can you, Carlos mentioned some of the access and isolation issues. Can you talk a little bit about how you're approaching that?
Sure, Libby, thank you. And thank you, Rosie and Carlos. Great job. So at Rancho, we see over 80,000 patients a year in our outpatient services division. And as you know, our patients, we have a very unique patient population at Rancho. Pre-COVID, we were seeing 80% of our patients in person in our clinics, with the other 20% being provided service through phone visits. At Rancho, we started our phone visits in 2015. It was actually a necessity. We started this through a quality improvement project. The reason was we switched over to an electronic health record. And in doing so, we had to reduce our patient panel size to 50%. And so we thought in outpatient that a great way to be able to continuously see patients was to create this phone visit model. So when we started to become affected this year, early this year in March, by COVID-19, it was much more easier and much more fluid for us to really transfer our service over to telehealth and phone calls. What we have today is about 90%. Well, we started off in March. In March, we had about 90% telehealth visits versus 10% face-to-face. The issues that we encountered as we moved along showed up in specialty clinic. A lot of our specialty services that were not on board with the telephone model or the telehealth model. And so those were the issues where we really faced some access to care issues. Fast forward to where we're at today, looking at where we're at, we started reactivation in our outpatient clinics. We're actually up to close to 50% back to seeing patients face-to-face across primary and specialty care. And we did this very slowly and systematically across the entire outpatient services division. One, to reduce the risk of infection. We were mindful, just like you do at your grocery store, creating a distance with folks, social distancing, making sure things are wiped down, making sure the aisles are separated out. We really had to use these kinds of models in our hospital. So when you come to Rancho now for a visit, you will be social distancing. You will notice that our waiting rooms are not full of patients in one specific area. We've spread people out. We've turned over couches so that they're not able to be used if they're not within 6 feet of distance. And for us, being that we have patients in wheelchairs, motorized wheelchairs, manual wheelchairs, these take up a lot of space. And a lot of our patients might come with their families and caregivers. For one appointment, it's a huge family affair. And so, you know, the restrictions on visitors, you know, we had to be very careful when we administered some of these policies. They are allowed to bring one visitor with them, one person to help push them if needed. And if they don't need to be here, then they won't be at the facility. But we've actually been able to see our patients through virtual care. It's been great. We have a great team, an amazing team. It's really lit a fire into the whole system to develop a platform for video visits, a model and a plan that wasn't in place prior to COVID-19. And so this is great news for patients that might be able to utilize this service in the future. Telehealth is not for every patient, we understand that, but it is for some patients. Some people would appreciate a phone call. I found that in my own experience, dealing with my healthcare system, I've utilized a phone visit, and it's been great because I could do it here in my own office at work and not having to leave Rancho. And so these are the kinds of things that we've experienced over these past few months in terms of access to care issues. And we have worked closer with the specialty clinics, brought them on board as well. Rancho became a surge hospital. We've decompressed all other county facilities, all other county hospitals. So we have not stopped receiving large amounts of patients here to decompress other hospitals. And we are now in a phase where we are able to actively reactivate our outpatient services division. So we're looking towards moving up to about 60% from where we were at before with face-to-face visits.
Great. Thank you so much, Gilbert. I think, it sounded like you had some of those foundations for the massive movement to telehealth overnight or just about overnight, which I'm sure, helped. I know Eli, Virginia Mason went to virtual visits and telehealth, telemedicine. If you want to give us a little bit of insight of what that looked like for you and how your advisors were involved in that.
A lot of parallels to what Gilbert talked about, I think. And if I was on this call a year ago, I think this would feel like a more positive story. So I think I'll maybe talk about some stuff that hasn't gone great and what we're learning from it. Mm-hmm. And a lot of this has been related to the speed element that I was talking about and Gilbert's addressing as well, right? So we had this great, 3-year plan to get virtual health a little more up and going. We have a lot of patients that come from like Alaska and Idaho, so we were directing most of those efforts on people that weren't in our backyard. Mm-hmm. And then of course COVID hits and we have to pop this up in a month with a command center type structure. And so we did none of the great ambitions around patient co-design that we had on the game plan and we're in the process of, just for the sake of we had to get it up, we had to stay in business, we had to keep people safe. And so now I think we're kind of in debrief mode around, as we have a little bit of a moment to breathe and think about kind of the fall and going forward, pulling in more of our patient family partners and others to say what's going well, what's not. I think we're experiencing many of the benefits that Carlos and Gilbert and others were alluding to, but there's also a lot of challenges when we start to kind of study this and hear the patient's perspective around maybe not the lack of privacy in the home that I would want, or certainly like the disparities in access to technology. And so we're trying now to sort of design like what would be sort of our Virginia Mason branded, virtual experience. We think we can influence that more in person than we can virtually historically. So I think that's some of the improvement work that we're doing now. I think the other, I think virtual connections, I think beyond the clinic as well recently too, right? So we hadn't spent a lot of time thinking about patients and family members virtually connecting to patients in a hospital bed at end of life care in the way that we were forced to think about before. And so we also didn't have a group of patient family advisors that were experiencing COVID in a hospital bed nearing the end of life with no visitors coming in. And so I think it really kind of forced us to go to the actual patients experiencing the actual care to get snippets of input. And as we designed kind of rapidly, like, take iPads to the bedside and allow their family members to talk to them. And obviously that's evolved quite a bit over the last 6 months. And then I alluded to it earlier, but I also think, virtually connecting with our patient family partners in general has been a good challenge for us, I would say. So over the summer, we tried to run kind of more of our traditional model when we were trying to do these little improvement activities. related to all the things we were working on. And we had some facilitators that were really having a hard time with some people in the room, some people at home, different technology platforms, different skill set. And we actually got the input from our patient and family partners that they were feeling really disrespected in that experience. They were cutting out, they weren't part of the conversation, they didn't have access to all the handouts, they couldn't go and do the tour that the other team was seeing. And so it was creating exactly the opposite experience that we were hoping it was doing.
Interesting.
And so they're now working with us to say, you know, what would be with our IT department, our experience group, and our patients, what should a virtual connection look like that actually feels useful? And, you know, I think we've got a nice dialogue going here and it feels healthy, but if half of us were in a room and half of us were here, it might feel different. So those are just some of the things I think we're kind of wrestling with. And one of my favorite things is when the right thing to do for our patients also feels like the right, you know, business opportunity. But I think this idea of if we can make virtual connections feel more respectful, that's really going to help us on kind of our equity work, but also some of the, Rosie was alluding to kind of that urgency and speed, and we need input, but we want it to be respectful and have a meaningful dialogue. And so we hope that some improvements on that in the next, you know, kind of quarter is going to help us with a lot of those different efforts.
So it's like simultaneously improving the improvement process
Yeah.
while working on the respectful virtual visit. I really, I see the challenge and I appreciate it. I think what's so important is that you're continuing to reach out. Well, you're fortunate in that you have this history of a respectful partnership with your advisory community that you're leaning into for how we're going to do this in the future in a respectful way. And so you're able to hear them when they say, you know, we might need to tweak this or that. I think that is just so critical. I mean, I've talked with so many health systems who have moved to this virtual model so quickly. Like you said, we've all said this sense of urgency has been just crazy. So how could we possibly expect that we would make a shift like that and do it without any problems, any errors? So you know, for so many health systems, I just want to offload that burden to think you have to have gotten it right on the first try, and just open the doors and talk with your patients and families about how they're experiencing it, because sometimes it's a respect issue, but sometimes it's a logistics issue that's fixed really easily. Have you found any of that kind of input been helpful in how you're thinking about your virtual program?
I mean, just some little things like, can we check out a laptop that's already has the simple setup for a Teams meeting to someone who's intimidated by technology or doesn't have the, you know, to your point of logistics, it's some little things like that, or it's, you know, in the warm-up activities and introductions of a facilitated event, is there a little part of it that's how are you experiencing this meeting? What are some of the connections? What are your fears both around this topic, but also around how we're actually going to connect and talk to each other, or breakout rooms? And so, I mean, I guess the short answer is we're experimenting and we're getting some little nuggets of success, but we don't quite yet. You know, we always love to have the best practice standard, and I don't know if we're there yet.
I think that's a reasonable expectation given the circumstances around us. I just, again, really appreciate the culture. And I'm going to go back to that with you for a minute. The culture at Virginia Mason so clearly, I've never even set foot on campus, but so clearly to me is all about continuous improvement. And you spoke also about the expectation of patient and family partners to be part of that process. Can you pull out sort of what are those elements that created and sustained that culture?
I mean, that's a big question, but I'll take a crack at it.
I know, sorry.
No, it's great. That's why we're here. You know, I think it starts at the top, but I also think it's sort of like reinforced from, I think, all the voices that we can get. So, you know, starting from the top that our board and CEO have kind of declared patient first. In a way that probably every healthcare institution thinks they're doing, but then I think they try to really, you know, back it up and keep their learning kind of cycle open, and in the sense that every board meeting kicks off with a patient story and they try to alternate, you know, positive and negative. Every one of our executives is asked to lead an improvement event every year. And part of that is you go out and you interview patients and you interview the customers that you're working on improving. And so I think we're kind of, you know, forced, how do you say that in the most respectful way? You're kind of forcing some of those connections in a way that it kind of helps make it clear when it's working or when it's not working. There's certainly like leader rounding and expectations to go both know your satisfaction data, but also go and get some actual, conversations and voices with our patients. But then we try to reinforce that, not just from, led from those, I think at the top end, those potentially in privilege, but this large patient family partner pool. And obviously in healthcare, there's so many passionate team members that have much greater connections to kind of the day-to-day patient experience than senior leaders, for example. And so how do we try to really, highlight those kind of quotes, voices in our managers meeting and our improvement activities. And I think I mentioned earlier, we, by policy or by expectation, required patients to be at the table during certain events, certain guiding teams, certain interactions. And so that's obviously been a journey over, 20 some years, but I think those are some ways that we try to kind of keep it alive and not let it be something that can slip for us.
Well, we over here appreciate a good nudge in the right direction. That's a ensuring the expectation is set. Thank you so much. So I want to turn to a question that came out yesterday, and I think I've seen it in the chat box here. And I would invite all the participants to go ahead and put your questions into chat box, and we'll try to get to as many as we can. And that is about the family presence during COVID, and how are we experiencing that? And Rosie and Carlos, I'd love to hear your perspective on sort of the balance of infection control and the humanity of being hospitalized alone.
Libby, this is Rosie. I can tell you that I alluded to the fact that I lost my husband, and I lost my husband very quickly to cancer, and I was being told I couldn't be part of his care and walk the journey with him as I described it. And it was hard, and I fought hard to get at the table and to be with him. And I look back at it and I think, what could have I done differently, and what could have they done differently? And I as I've been speaking about this and thinking about it, I think that sometimes during this COVID time, we've gotten so strongly focused on that piece, on being safe and making sure we follow all the rules. And we have given jobs to individuals to say, this is your job. You need to take the temperature. You need to make sure nobody gets in. You make sure. And we don't empower them to then also look at the other side, the humanity side, the compassionate side. There's a point in a time in everybody's journey when you might need. And sometimes, a physician is saying, oh, yes, David asked the physician and said, can Rosie be with me? And he had said yes. And then the front office would say, absolutely not. And it got to be a real struggle. And David was saying, I need Rosie because I'm having some issues just understanding what's going on. And I think that, sometimes we give a job to somebody and they have that job, but we don't empower them to step outside of the job, to be humane, to be compassionate, to show empathy, and that balance. And I've been talking to a lot of leadership about this, and a lot of them are struggling with this and getting to that balance of how do we empower the people that we give responsibility to. They have big, you've given them big responsibilities, and yet we haven't empowered them to be also the compassionate side.
Yeah, I think you bring up a great point. I think that, there's fear on all sides. There's fear all around, right? Especially in the earlier months of the pandemic. And I think we have to intentionally continue to look at those policies and continually weigh in. I know Susan Frampton and her colleagues at Plaintree developed a guidance document for family presence during this time, and really key considerations. And I think that's the point. I don't know that there's a perfect answer to this. If anybody's got it, please raise your hand and share it, because it's needed. But I think there are some things we ought to be thinking about in each of the settings that we're in, whether we're inpatient or attending with a loved one to an outpatient visit, or in a nursing home. We've really got to be intentional about how we're setting up this balance of infection control with family presence and humanity. Any others want to comment on that?
Um, yes, Libby, my name, I'm Carlos. I'm sorry.
Thanks, Carlos.
Yeah, Rosie has a very good point. You know, I've listened to everything Rosie said. Um, but as far as from what I've witnessed, over at Rancho, we have a couple of organizations like No Barriers, who are peer mentors and peer educators. So a lot of times what we do among ourselves is, you know what, since we keep in touch with each other so much on the internet, socially, and on account of the Zoom meetings, if we know somebody that's in the hospital, one of our patients or somebody, one of our friends that's in there, we get messages to them through No Barriers. We just want them to know that, you know what, there's somebody out there always thinking about them, you know. Our No Barriers patients, I mean, our No Barriers mentors, they visit patient rooms. Okay, so we do try and bring the hopes up of the patients there. You know, we try to let them know that they're not alone. And it is a difficult time. And if I can just address something that somebody put in here,
Sure.
how to connect with patients electronically who lack the knowledge. At Rancho, when you come in our office and even in the wellness center, we have a patient peer mentors, patient volunteers that'll sit there with you and they'll go over these classes. They'll show you how to use your computer. They'll help you set up the portal and DHS. They'll sit there with you I've sat there with people in Spanish and in English for over an hour, hour and a half with some people, trying to explain them, walking them through the whole process so that I had them explain to me exactly what they were doing. So they'd have that little bit of emphasis. And, you know, a lot of times being taught by somebody that's at your level, or, you know, not an administrator, somebody where, you know, you're in there with intense fear, just a little open conversation, we found that it works a lot better. So, you know, at Rancho, we do have our patients, the family members, the grandparents, the caregivers, anybody that comes with them are welcome to come in, sit in the support groups and different things like that, and learn electronically. So when they do leave, they have the confidence that, you know what, they can keep in touch.
Great. Thank you, Carlos. It seems that so many of the solutions to the pandemic rely on electronic access. Yeah, and I think Bill's question in the chat is a good one. You know, how are we going to manage the so-called digital divide? Any thoughts, Gilbert or Eli?
You know, I would just piggyback off of what Carlos talks about. And I mean, I think this has really highlighted the importance of technology in healthcare. If there were any doubts before COVID-19,
Right.
this has really brought things to the light. As I mentioned at DHS, you know, we were kind of walking a very slow line towards getting towards telemedicine, telehealth. But I've seen huge strides happen literally overnight with this. And I feel like we need to develop more systems, just like Carlos points out at our patient resource center and our wellness center, our peer mentors on the units before you get into the hospital, in our plaza, out in the resource center, showing patients how to utilize this technology is key. And aside from that is really venturing out into communities where our patients work, live, pray, and play. Really pulling away from the bricks and mortar healthcare system. You shouldn't have to come all the way to Rancho just to learn how to use technology. There should be systems established out in your community. We really need to think about the virtual walls and how we can open up these walls. One great example that I've seen here at Rancho is through our wellness center. We have support groups, spinal cord injury support groups. In the past, these groups were tailored and designed for our patients here at Rancho, former patients, some community members. What has been great to see is how when they went virtual, there were no more walls. You didn't have to be a Rancho patient. So now they have patients from all over the country, all over the world, as part of this support group. And that's great to have that sort of influence with our technology. So I think the more we can do as a healthcare system to provide this kind of training and support, and really venturing out into communities and really opening up the doors for technology. There's a myth about our patients that come from low socioeconomic areas that they don't know anything about technology. That's a myth. You know, smartphones are so accessible these days. Phones are accessible these days. Technology is accessible these days. We need to make sure that they're able to access the Wi-Fi and networks and technology resources, and really empower them and encourage them. But we've seen a lot of our patients utilizing the technology, and if not, they can come over and Carlos and his team will help them out. So that's what I have to say about that.
I think that's so, you bring up such a good point. You know, the conversation years ago was, well, some people don't have access and still some people don't. We have to be very mindful of that. But I think the solution that we were thinking about 5 years ago was create more opportunities, whereas now I think we really need to support everyone to be able to have access digitally. So great point. Eli, did you have something to
Yeah, I think just the other thing that we're thinking about to supplement, not, I think we have a lot of similar thoughts to what's already been shared, but, we're also trying to think, some of this is hopefully short term and it's not great, and there's some ways we can make it better and there's some ways we can't, but we're also trying to think long term about what services should maybe live in a technological world longer term. So interpreter service is one that we've had a hard time getting an interpreter to the side by side with the patient in the way that they need it. And so we should be able to solve that with technology long run. And I know a lot of places already have. And then we're designing a new clinic, and there's just a whole nother line of thinking around physical flows, thinking about infection prevention and safety, and not, limited entry points or dual pathways for someone that may, have an infectious cough and those that don't, and pediatrics separated from other areas. And so a lot of stuff I think that we've thought about in the inpatient setting and some in the outpatient setting, but I think there's a lot more we can do in kind of those outpatient flows, flu shot, drive-through clinics, a lot of things that's kind of been on the fringe of normal that may becomes more normal after this, even post-COVID, hopefully.
I really like that framing, short-term and long-term. Go ahead, Rosie, sorry.
Eli, I was talking to a pharmacist yesterday, and he told me that in their pharmacy, they are now administering flu shots in a drive-through. So you can call when you get to the pharmacy and say, I'm here, and they will then go out to your car and administer the flu shot. So, there are ways around things that are, new ways of looking at things. And I'm involved in the redoing of a lobby in a hospital, and a NIC unit, and in all of it, we're looking at the two things: accessibility and infection control. And even the kind of furniture you pull in, all of those kind of things will help improve, the quality of, the quality. Even they are putting in registrations that are self-registration stations or docks, and they have a UV light that passes over them after each person registers to disinfect the screen. So basically, every time somebody registers, the UV light cleans it. So simple solutions to problems that we think are huge. There are simple solutions.
Yeah. May as well use technology everywhere we can that it makes sense. So absolutely. So I want to turn to a question Greg Merritt put in the chat box that we've been thinking a lot about and having many conversations about, because when COVID hit, the incident command centers got stood up in many of the health systems to organize their response to this pandemic. And in the early days, and that sense of urgency was so high. And that was a time where largely the patient and family voice was sort of pushed to the side, because those incident command centers didn't really have the structure for patients and families to inform. And one of the things that we learned was that most health systems have these monthly sort of emergency response committees that meet on a regular basis that then get implemented into the incident command centers when there is a crisis. And so what are your thoughts about engaging patients and families as advisors into the emergency response and the incident command centers? Do you guys have thoughts, or did you do any of that? If not, what did we miss out on?
We did not. just right off the bat. I think partly from just trying to get a handle on what was the game plan, and that wasn't kind of part of the normal in quote structure, kind of our traditional structure. So the short answer is we didn't in the early days, and we've had more success afterwards around when the command center has initiated a priority initiative. That's where we can go and pull in a patient. I think it's a good provocation, and I would say we probably haven't put kind of the reflective thought on that yet. But I think would be a good one for us to push ourselves on, whether if it's not on the first day, or maybe it is, where's the access, where's the input that we need, where is that going to be a help versus a harm, or where do you need some background training involved? And so I think the short answer is, right, I think that's kind of on our radar to reflect on, but we didn't in the early days.
What's interesting for me was that I was involved with a strategic planning day with a hospital like about a week before the pandemic hit, and they were looking at it. They saw it coming. They knew that they thought something big was going to happen, and so they pulled me aside to pick my brain, and said, what do you think we should be doing? How should we be doing it? And so those kind of things. And some of the things that I suggested, and one of the things was that there are several hospital systems in that community. And I said, you all need to be giving the same message to the public. You all need to be on the same page. You all need to be providing, looking at what your resources are and how can you use them. And it was interesting because I believe they should be a model for what happened, because their instant command center groups from each hospital met every morning at 7 o'clock together. And the message that came out from that community to everybody on every TV station and on every, email, and then every Facebook comment was the same. It was always the same. And everybody got the same message. And I keep saying that's the way people can learn trust. I have more trust in what they had to say than anybody in the country because of the fact of how they work together. And I mean, we always knew how many hospital beds were available. We always knew how many cases there were. We always knew, how they were looking at cases. We always knew where there were sites to be tested in that community. And that was, to me, phenomenal. And it's not a big community, but it's a community that has 5 different hospital systems. So if you're a Packer fan, or if you know Packers, it's Green Bay. It's Green Bay, Wisconsin, and they're known for being a community that works together for lots of things, and they did a great job at this. Nobody wanted to updo somebody else. They all wanted to do the best for everybody in their community.
Such a great model. I think that's really, that's it, right? Is we're thinking, and I think COVID has really forced us to think more about community and as the center of health, and Gilbert alluded to it as well. So with that in mind, and there are so many great, I hope you guys are all keeping an eye on the chat, because there are some phenomenal ideas and thoughts, and Greg is always coming through with the great questions as well. And Eli, I think as we move into that reflective period, right, where I feel like we're just getting into that, but it's so essential to hear from our patient and family caregivers how this experience went, and where we were sidelined, and where there were logistics that got in the way versus intention or concern, and how do we break that down. So I love that patients and families are part of your reflections and part of that sort of evaluation process. But I want to turn to something we dove into deeply yesterday morning, and that is that we know COVID has highlighted disparities in outcomes for people of color in this country. So how can patient-family advisory programs seek out the opportunity to expand into the community and really hear from voices and populations that have not been at the table, as we talked about yesterday? Or I loved the idea that maybe we should just throw out the table. But how do we just bring those voices in? So any thoughts?
Yeah, Libby, this is Carlos. Aside from Rancho, like I said earlier, I'm president of the LA County Commission on Disabilities. So I do sit in, and I do have a lot of different organizations that come speak to us. I've sat and I've been involved in a lot of for example, like the Homeland Security for disasters and everything like that. What I do is I'll bring that back to Rancho. Through the PAC, we'll discuss on what's out there and how will it affect our patients. And since we have administration that comes there, and Gilbert and other people that come there, they'll listen to what we're looking for, and we'll explain to them what's really needed for the patients. And I think the main thing is the communication, like it was said earlier. If you have an open door policy and you forget that, you know what, I'm administration or I'm in charge, and remember that, you know what, it's something for all the patients. That, go to community meetings, go to some of your local community meetings, bring your knowledge, go speak at these community meetings. They always want people to speak at them. Tell them what you're doing, explain to them, hey, you know what, even if it's a small 3 people meeting, you know what, if you get one person out of that 3 people, that one person will reach to another 5, 10, 15 people, they'll reach out to other people. So eventually, even if they're not electronically technology savvy, they'll get the message, they'll understand, they'll start asking. And that's when you get all your information, and you have to be transparent and share.
Thank you, Carlos. The opportunity for advisors to be connectors, like you said, I think is really an important resource to our health systems. Anybody?
This is Rosie. I think that, as we come back together and as patient advisory groups come back together, I think they have to look at their patient advisory groups and does it really reflect the people they're serving in that hospital or that community? I think that many times people at the table have gotten a seat and they've been in that seat for a long time. I always tell the story about going to speak at a patient advisory group, and I was moved 6 times because I was in somebody's seat. And I was like, okay, and first of all, moving a wheelchair 6 times is not fun. But anyway, I realized real quickly that, first of all, the 9 o'clock in the morning patient advisory council meeting that has assigned that people that sit in a certain seat has been around too long. And we have to look at, how do we juggle those seats? How do we move those seats? How do we move the people in? And I firmly believe that, the time you have your meeting and where you have the meeting and how you have the meeting and what you provide for the meeting all reflects on how you really know your patient population. Because you can't be inviting to that patient advisory council and you can't be bringing the real people to the table or to fill the seats if you don't know who they are. And so I always say, go to your emergency room or go to your lobby and just pay attention to who's coming and going and start talking to those people. I do some work with VA hospitals, and my theory is sit in their lobby and be the coffee lady for a while. And you'll learn a whole lot more about the VA population than you'll ever learn in any meeting at the VA. I just, I always say the coffee lady has the answers. And that's the lady I want to be, because I think I could learn a lot more about how to be support to them than ever going to their meetings.
Mm-hmm. Well said, Rosie. I've always said coffee is the international sign of goodwill. Anybody in the hospital or health center that offers me a cup of coffee tells me they care about my comfort. So absolutely.
If you had a sandwich to that at 6 o'clock at night, that makes a big difference too.
Bonus. Gilbert or Eli?
I would just say, Rosie and Carlos could not have said it better and more clear. I agree with both of them. Really, I think about reaching out to the folks. I think about the mother with 2 jobs that can't ever make it to her PTA meetings or to her school board meetings to represent her child at these meetings. So, where would she sit at our table at a PFAC meeting? And
Right.
Are we customizing our schedules for ourselves, or are we doing it for our community? Or how are we integrating folks from the community? And what does that breakdown look like if you really break down the diversity within your group? I know at Rancho, at our patient advisory council, we have we look at every element from disability to gender to race to place. We really think about who's on our council. We try to get that breakdown, but I think we need to be more inclusive in that. And we need to be more intentional about who we're inviting to be part of our council. Rosie said it right. Some people might sit as incumbents on a seat for years and years and years. And we really need to think about how we shift that. Also, we can do more as a healthcare system in terms of our outreach, really injecting ourselves into the community, being able to provide service, the virtual aspect of it. I'll go back to technology. And utilizing that to draw people in and open up more doors for our meetings and having the support. I do want to acknowledge that one thing that I want to thank our Patient Advisory Council for the shift that they made in terms of the first meeting when I came back during COVID-19 when we had our first meeting with our Patient Family Advisory Council. Our first meeting a couple of months in, and, the issue on the table was no longer, Gil, we want to build this mural in the parking lot and we need this, we need to get this managed. And we also need a new table, in this area for our patients. I want to say that they became a bit more gentle in terms of those priorities, and they were able to shift their priorities as well with working with administration and realizing that we were under huge amounts of stress, and that there were many people dying around us, and that people are being impacted in so many ways, psychologically and physically, not just coworkers and patients, but also our communities. And so I do want to acknowledge our patient family advisors and how they were able to make that shift in priorities. And so I think that's key too. How do we exchange that information and be a bit more gentle with each other, and really think about how we can, have a greater impact through kindness.
True partnership. Thank you, Gilbert. Eli?
I think the two things I might add to this conversation from our Virginia Mason perspective is that I think we've opened our eyes recently that we've been so focused, I think in a good way, on matching our patient family partners to the patients we're serving. And I think we've really opened our eyes that there's a lot of patients we're not serving that we could or should be serving. And so thinking about kind of our underinsured, underrepresented voices. And so I think your provocation on kind of what are our community connections that aren't, maybe they're flowing through our walls currently, and maybe they're not. And I think we are always trying to think about kind of how to, so today it's about how do we systematize equity. It's used to be how do we systematize quality. And so we can't be reliant on a couple of voices or a group of voices. So we're running an improvement activity actually this week about every time we run a workshop, from what are we studying to who are we inviting to what are the kind of voices that we're bringing to the table to advise us each time, how are we doing that in an equitable way from a racial, economic, et cetera, right? What are all the different perspectives we want to think about?
That's fantastic. I love that. Systematize. I can't say it, but I think the concept is brilliant. Equity. I think that's just awesome.
Libby, I was on a meeting this morning before this presentation, and it is a community group, and it's a statewide community group that helps patients self-direct their own care. And so it's a national, and they are talking about the same issues we just talked about. How do we bring more people to, that really of every culture, of every color to the table? How do we make sure that we're representing the whole communities and all the communities? And so, we're not the only ones talking about this. And so maybe we should be reaching out and talking to our communities. Mm-hmm. And, I threw a suggestion out there in the chat box. Maybe we don't have to have our patient and family advisory council meet at the hospital or at the facility. Maybe we meet at a community center, or we meet inside the community that we work. Where do they hang out? Where does the community meet? It might be McDonald's for all you know.
Right.
You never know where you can pass over that cup of coffee and really make it work.
Absolutely. Well said, Rosie. Well, we are right up against time, and I know we've got anxious presenters ready to go lined up. So I just while I'm thanking our panelists today, I would like to invite everyone to chat into the chat box. What is one insight or idea that you will bring back to your organization from this discussion? Rosie, Gilbert, Eli, Carlos, thank you so much for giving us your time, your energy, your insights. It's been such a valuable hour with you. I think we could continue for multiple more hours, but for now we'll have to say goodbye and thank you so, so much.
Thank you.
Thank you. Appreciate it.
Thank you.